as surgeons, we have been looking for the evidence that local regional treatment plus optimal systemic treatment could improve overall survival in women who present with de novo stage 4 breast cancer. However, we have only retrospective studies with selection bias. This study, I think, you presented in ASCO 2020 fills in this gap. It's a randomized controlled prospective study. So my question is, could you please share us the most important results or conclusions from this research? Thank you.
So the primary endpoint, the main reason for doing the study was to assess whether or not the use of local regional treatment for the intact primary tumor would improve survival in women with newly diagnosed stage 4 breast cancer.
Yeah.
So the main finding of our study was that among women who received local regional treatment for the primary tumor, the survival experience was the same as women who did not. So we randomized women after they had had a period of initial systemic therapy, and those who didn't progress during that time, so their disease was at least somewhat responsive to the treatment that they were receiving, they were then randomized to local regional treatment or not. And the group who received local regional treatment survived exactly the same as the group who did not. So I think that's the main finding from the study.
Yeah.
Do you think if we select a cohort with partial response for systematic treatment rather than low progressing of distant disease following 4 to 8 months of therapy, maybe we would get a positive result? And I just want to know what's your real point about this one.
We did not distinguish between stable disease and responsive disease, but many women had responsive disease. As you know, the treatment for breast cancer now is associated with response rates somewhere in the 70–80% range. So of the women who were randomized, the majority would have responsive disease, and we did have a good proportion of women with HER2 positive disease as well. And so, as you know, HER2 positive disease responds very well to HER2 directed therapy, and these women did receive HER2 directed therapy. So at the moment, we don't have any suggestion that women who responded well to treatment did better with local regional treatment than women who didn't respond well. So in our subset analyses, we found that women with HER2 positive disease also had no survival benefit from the use of local regional treatment, and women with hormone receptor positive disease, similarly, no survival benefit with the use of local regional treatment. Among women with triple negative breast cancer, we found that women who received continued systemic therapy, who did not receive local regional treatment, seemed to do better. But that was a very small number of women, so it's hard to draw any conclusions from that. But among women who generally demonstrate response to local regional treatment, HER2 positive, hormone receptor positive, they did not experience any benefit from the local regional treatment.
Comparing with the other two prospective studies like MF0701 and TBCRC013, I think the design of this study is more similar to TBCRC013, which is screening effective patients response patients for local regional retreatment after systemic treatment. Negative results were also obtained, while in MF0701, when we do surgical treatment firstly, we also obtained when we do surgical treatment firstly, then followed by comprehensive treatment, obtained the result that surgical treatment could improve the progressive. So how do we understand this difference?
That's a good question, and the difference is actually hard to understand because I think we would all agree that the reason women die with metastatic breast cancer is because of distant disease, not because of local disease. For the great majority of women, the cause of death is distant disease. So in someone whose distant disease is not responding, the idea that local regional treatment would provide better benefit is contrary to the way we think about breast cancer biology today. And so it is a little counterintuitive that studies that use systemic therapy first don't show a benefit, whereas the study that used local regional treatment first shows a benefit. I don't know that we're going to have that question answered for us unless, our Chinese colleagues decide to repeat MF0701. So if you decide to repeat the study that was done in Turkey and get similar results, that will tell us something new that it will teach us something new. But in the absence of another study replicating the results of the Turkish trial, I think we are left with a little bit of a quandary, because biologically it's not rational that the use of local regional treatment in women who may be non-responsive to treatment would provide a benefit. And the problem with randomizing at the beginning, randomizing women who have never received systemic therapy, is you don't know whether their systemic therapy is responsive or not. I think the other thing to remember is that these are all relatively small trials. So, the way we overcome bias in randomized trials is with large numbers. Unfortunately, we had to cut back our sample size. We had originally planned to recruit 880 women, and we eventually recruited only 390. But the results are so null that I think if we had actually enrolled 800 women, I doubt that would have made a difference. There is not even a hint of a benefit to suggest that with a larger number we would have had statistically significant results. But I think that contradiction between the Tata Memorial Study, E2108 on the one side, and the Turkish Federation study on the other side, that is a difference that is puzzling. And so I guess I would, challenge our colleagues in China to try to replicate that experience. Although I have to say that there are questions that have been raised about the design of the Turkish study and the randomization between two arms. If you remember, there was some imbalance between arms, with women who received surgery having better prognostic features than women who didn't receive surgery at the beginning. So, I think that we need to break that tie. And obviously you remember that our Japanese colleagues have a study that will mature in 2 years, which is
JCOG 1017.
1015. So the Japanese trial hopefully will provide additional information. Their design is similar to the E2108 design. They are using systemic therapy first and randomizing responders, because I think for most of us who looked at this problem and started thinking about designing trials, that seemed to be the rational design.
Yeah.
And then the other study I would mention, just as a reminder, although it was very small, was the Austrian study. Right, the Austrians have done the positive trial that was published, I think, 2 years ago. And although they had only about 40 or 45 women per arm, their design was similar to the Turkish study. They used surgery first, so their patients did not get an initial period of systemic therapy. They were randomized at enrollment into local regional treatment or systemic therapy. And although their trial was very small, it also pointed in the same direction as the Indian study and E2108, not showing any benefit for the use of early surgery and radiation.
I think, Dr. Cohen, your answer is very impressive. And as you said, and a random trial with the incorporation of exciting correlative science ideas has bigger potential rewards for our patients. This is your word. And I think E2108 just changed my assumption, a lot of people's assumption. Actually, I can accept the selection bias of surgery for patients. Can you give me some advice about how to promote the quality of life for metastatic breast cancer? Thank you so much.
So how to promote the quality of life for women with metastatic breast cancer? Well, I mean, there are many aspects to quality of life, obviously, and we always have to balance the quality of life effects of the disease. And metastatic breast cancer is often a very symptomatic disease. So clearly the disease affects the quality of life, and then the treatment affects the quality of life. So that is always the balance that we have to try to reach. And I think that to the extent that treatment controls metastatic disease, it improves the quality of life related to the disease. And then the toxicity of treatment is something that needs to be considered. And clearly less toxic treatment will have a lesser impact on quality of life. So, I'm not a medical oncologist. I don't have to make these decisions on a daily basis. I know that in China, you also manage chemotherapy, although not in the metastatic setting. Is that right? So Chinese breast surgical oncologists manage chemotherapy for adjuvant settings, not metastatic. Is that correct?
Yeah.
Yeah. So yeah, I think that is the challenge, and paying attention to the toxicity of treatment while achieving good responses and controlling the symptoms of metastatic breast cancer is the goal. Specifically in terms of the effects of local regional treatment on quality of life, the way we set up our quality of life analyses was that we anticipated that local progression of the tumor would impair quality of life to some extent. And we know it does that in women who have large tumors that are fungating, or they have skin nodules, or they have pain. So there are many aspects of the local treatment that can impair a local disease that can impair quality of life. But when we apply local treatment, then the surgery and the radiation also has an impact on quality of life. So in our trial, we were not focusing on palliative local regional treatment. We were focusing on local regional treatment that was delivered in the same way as it is delivered for women who have non-metastatic disease. And it was delivered to women who had no symptoms from their tumors. So in that setting, when the local tumor is not causing any symptoms, it seems, at least on our initial analyses, that the symptoms related to treatment also have a significant impact. So in the asymptomatic patient, adding the symptoms related to treatment, the symptoms, the side effects of surgery and radiation do have an impact on quality of life, especially what we saw was the biggest impact was at 18 months. So we had expected that women would have recovered from surgery and radiation by 18 months. So the immediate short-term impact of local regional treatment would have resolved. What we saw was that the only time point where quality of life was different in the two arms in terms of the local regional area was at 18 months. So we still have to explore that a little further and look at the details of the quality of life responses. I think these conclusions are somewhat tentative at the moment because the number of women who completed the quality of life surveys was not ideal. So there was a fall off in the submission of quality of life surveys as the trial progressed. So there were fewer women who completed the quality of life surveys towards the end than at the beginning. So the conclusion, I think, the firm conclusion that we can reach is that local regional treatment does not improve quality of life, at least for local regional symptoms. But, you know, whether there's a difference between arms, that's a little bit more questionable.
I think as the Professor Seema's conclusion, when systemic disease is well controlled with systemic therapy, but the primary site is progressing, this time the local surgery may be considered. Yes?
I think that's a reasonable strategy. I mean, clearly we've all seen women with metastatic breast cancer whose local regional treatment is causing them a problem. And we have also seen, as is demonstrated with our data and also the other two trials that have been completed, that for the majority of women who are responding to systemic therapy, they respond not only at distant sites, but also locally. So the local tumor, if it's ulcerated, will often heal. You know, if it's large, will often shrink. So successful systemic therapy can control the local tumor as well in terms of symptoms anyway. So, so women who get effective systemic therapy don't very often have symptomatic local disease. If the distant disease is responding, the local disease also responds. There is a small group of women, though, in whom the distant disease seems well controlled, but the local disease is progressing. I've seen that. I'm sure you have too. And in that situation, I think to offer women local treatment, if that is what they would like, and if that is what their doctor feels is appropriate for them, would be reasonable. But the thing that we must remember, because women with metastatic breast cancer usually are seeking treatment that they think will extend their survival. So we must remember in talking to women about local regional treatment for the primary tumor that we cannot anticipate improved survival. What it might offer them is to have, you know, longer term better control if the local tumor is progressing. But if the local tumor is well controlled with systemic therapy, I don't think there is an advantage to offer with the use of local regional treatment.
I'm very agree with it exactly. So clinically, in my clinical, I think the response to the primary site and the distance is sometimes very different. So I'm very agree. Right. Yeah. So next question of me is relative to this. Some researchers suggest that if we resect a primary tumor, the judgment whether the subsequent systemic treatment is effective may be not accurate comparing with no resection. So could you tell me some information about this point?
So you mean if the the primary tumor is an indicator of response, so the primary tumor is a site that we can follow to assess response.
Yeah.
And if the primary tumor has been removed, then we cannot assess response as well.
Yeah.
So, well, that it's true that the responding primary tumor does tell us that the treatment is working. And in general, the response at the primary site is in concordance, is similar to response at distant sites. But as you just said, that's not always true. So when we're treating women for metastatic disease, we can follow the intact primary tumor for response, but we also generally follow the distant disease for response, right? So the responding distant disease has to be assessed separately from the responding primary tumor. They often go together, but they can be different. So each disease site, the primary disease site, the main disease site. So in a woman with bony disease, the bony disease has to be assessed. The primary tumor response will often be concordant, will be in agreement with the distant response, but not in every patient.
Following 4 to 8 months of the response therapy, is it enough for the, objective time?
Right. Yeah. So that's a good question. And we actually struggled with how long to define that interval of initial treatment. If we let it go too long, then we're not using local therapy early in the course. And, one of the theoretical premises that the trial was built on was this idea of reseeding, that the primary tumor site is actually something where circulating tumor cells can recirculate through the primary tumor and become more competent to set up new sites. So if we leave the primary tumor alone a long time, then we may not see the benefit of resection of the primary tumor. But if we don't treat long enough, then we may not get, because particularly with hormone receptor positive disease, it can take a while to see responses. So the 4 month, the shorter end of the limit of 4 months was based on the idea that most chemotherapy regimens need to go about 4 months in order to declare response or not. ACT, for instance, sequential ACT goes for 4 months. Most of the medical oncologists in the group felt that 4 months was a good minimum interval. And then the maximum interval we set based on endocrine therapy, because you don't often see a good response to endocrine therapy in less than 6 months, and just some flexibility. So that's how we set that interval of 4 to 8 months. But the intent of the trial was really to assess the value of early local therapy. So we want to make it open-ended, that you can treat the patients as long as you want and then randomize them. So we have to set some interval to make the population relatively homogeneous in terms of the duration of the treatment. So that's how we came up with the 4 to 8 month interval. In practice, however, obviously systemic therapy goes longer than 8 months. It goes as long as necessary. So in practice, that 4 to 8 month interval is not particularly important, particularly since our results did not show value for early local therapy. So if we follow the results of the trial, then we won't have to make this decision of when to offer early local therapy, because the trial shows that early local therapy is not beneficial in women whose tumors are asymptomatic.
And I think Dr. Khan's your answer very impressive, and you just changed some of my viewpoints about the local therapy about the metastatic breast cancer, and I had another question, and I just noticed that in your result, the health-related quality of life was significantly lower in patients receiving early local therapy at 18 months post randomization, and the adverse effect of surgery and the radiation appears to balance out the gain of in quality of life that were achieved with better control of the primary tumor. And maybe you can give us more details about it. Thank you so much. I just want more details. Thank you.
Right. So unfortunately, we don't have more details at the moment. We are looking more closely at the quality of life data to try to understand why that 18-month time point was different. As I mentioned earlier, the response rate, declined through the course of the study. So we had fewer women responding with their quality of life surveys. So the information is not as robust as we would have liked. But my guess is that, what we had hypothesized was that the side effects of surgery and radiation would have gone away by the 18-month time point. This was 18 months after randomization. And it's possible that in some women, the surgery and radiation was a little bit delayed, so that by 18 months, those acute effects had not subsided. We did, of course, see an improvement in local control. So women who had local regional treatment were less likely to experience progression at the local site. So despite the lower rate of local progression, we did not see improved quality of life in terms of local symptoms. And this may be just a reflection of the tail end of the acute effects of surgery and radiation. So we do need to look at that data more closely, and we hope to be able to report those findings in greater detail in our manuscript.